Welcome back to the EMS Edge. Please go ahead and like, subscribe, hit the notification bell so you can be notified when I make new videos. Today we're going to start with junctional rhythms and move into section 2, which is AV blocks. Going over some of the basic anatomy of your AV node, and it's composed of really several different zones or areas. First, we're going to start with what's called our approach, and this is just a small area of tissue that's non-conductive, and it's where all the impulses coming from the atria they come to before they move into what we call the transition zone. Now, before I move into the transition zone, the vast majority of us, we only have one approach, right? So we only have one approach zone. Some people have two tracks that approach the AV node, and those two tracks have different characteristics, where one of those tracks is faster but has a slower refractory period, and the other sends the impulses slower but has a faster refractory period. And if you remember the atrial rhythm lecture that we talked about when we introduced a re-entry circuit, those are the two characteristics you need to start a re-entry pathway, and we'll talk about that a little bit later in our lecture today, but for now I wanted to introduce that. In our transitional zone, so right here in the transitional zone, this area is what we would refer to as an arrhythmogenic area. And it's arrhythmogenic because it's where you find a lot of our autonomic nervous system fibers. So those adrenergic and cholinergic nerve fibers are in that transition zone, and that's one way that the nervous system can have some control on increasing and decreasing heart rate depending on your situation. The core of our AV node is called our compact zone, and this is where you're going to find the automaticity or the pacemaking function, right? The pacemaking function of our AV node. Next, we have the bundle of His, and its job is to send the impulse very quickly to the bundle branches, right, to our bundle branches. And that's the basic anatomy of our AV node. At about 90% of us, 90% of our blood flow to the AV node comes from the right coronary artery, and about 10% of us, it comes from the left circumflex artery, right? In MIs involving the inferior wall, these are commonly associated with AV blocks and bradyarrhythmias because this AV node is in a way being directly affected by that decrease in perfusion to the heart. So because our AV node has three different identifiable zones, depending on where the impulse is originating at in the AV node, it can give rise to different P wave morphology. So when our AV node functions as our primary pacemaker, the location of that ectopic focus is going to influence the complex, mainly our P wave. So in this first drawing here, this P wave is coming from the transition zone, right? This P wave here, where we have an inverted P wave before the QRS complex, that likely is going to also have a shortened PR interval. This drawing here is coming from our compact zone, where in the compact zone, the P wave is kind of superimposed in the QRS complex to the point that we likely don't even see it on the EKG, or we see a slight change in the morphology of the QRS complex that is likely the P wave causing that. And then lastly, we have the bundle of His down here, which is this P wave here, where the P wave occurs just after the QRS complex, also changing the morphology of the QRS complex. And as we've talked about in leads 2, 3, and AVF, for junctional rhythms, the P wave is going to be inverted, and that's because the impulse is being conducted back into the atria instead of being delayed as it comes from the atrium. So our P wave would be inverted. And anytime you're trying to determine, is this a junctional rhythm, make sure you take a look at the PR interval. If you have an inverted P wave just before the QRS, and a shortened PR interval, that's highly suggestive of a junctional complex. Now that we've discussed the normal anatomy of an AV node, we can get into the different types of junctional rhythms. So your AV node is going to have an intrinsic rate of 40 to 60 beats per minute, right? And that can happen if for some reason there's a slowing down of the atrial rate. That's going to trigger a junctional complex to basically save the heart so that the ventricles depolarize. Because always remember that the ventricles are what is responsible for creating our cardiac output and creating our pulse. So without that, you have hemodynamic compromise and sudden cardiac failure. So the junctional escape here is saving the heart from not beating. You can have premature junctional contractions. You can have a junctional tachycardia where there's an area of tissue inside the AV node that is more irritable than the rest, and it starts to fire above its intrinsic rate of 40 to 60. And then the next type of junctional rhythms that we see are our reentrant tachycardias that we'll spend some time on in some later slides. Also, with a junctional rhythm, you should typically expect to find a narrow QRS complex unless there's something else like a bundle branch block later down the line causing it to be wide. A premature junctional contraction is most often non-compensatory, meaning that it resets the SA node. It's typically caused by increased automaticity somewhere within the AV node or junction itself. And your morphology of the PJC is going to be what you would expect with any other junctional complex. You would see maybe an absent or even a buried P wave. If you see a P wave, it's going to be inverted in leads 2, 3, and AVF, and you should see a narrow QRS complex. It can be difficult in some cases to differentiate a premature atrial contraction from a premature junctional contraction. In that case, what you're really looking for is looking for a buried P wave before the QRS complex. Is that P wave buried into the T wave, and is it upright? With a PAC, the buried P wave before the QRS complex, it's likely in the T wave. So you're looking for the difference in morphology there to justify is it a PAC or a PJC. For a PJC, an inverted P wave in leads 2, 3, and AVF with a short PR interval would be highly suggestive of this junctional premature contraction. Here we are looking at a junctional escape rhythm or a junctional rhythm. It looks exactly like a sinus complex, except it doesn't have a normal P wave. A junctional rhythm would occur when you have at least 3 junctional complexes, and what's basically happening is the SA node fails to fire, and the junctional area realizes this, and it begins to initiate the pacemaking duties to keep the ventricles from going into a standstill. Basically what happens is the atrial impulse just dies off before it makes its way to the AV node, which causes the AV node to have to take over pacemaking duties. And that's what we see on the screen here with our junctional rhythm. And I have 2 types of junctional rhythms. One, you may see at the top here where you do not have any identifiable P waves and a narrow QRS complex, or down below here where you have these retrograde P waves. So these retrograde P waves with a shortened PR interval would be consistent with a junctional rhythm. A rapid junctional rhythm has 2 types of rhythm variations, an accelerated junctional and a junctional tachycardia. And quite simply, they're just differentiated by how fast they are, where accelerated junctional is between 60 and 100 beats per minute, and a junctional tachycardia is greater than 100. Looking at the EKG above here, we're looking at lead 2. You can see that I have a fast rhythm that is at 300, 150. That is greater than 100 beats per minute, so I'm dealing with a tachycardia. It's regular. I have P waves. They all look the same, but they are inverted, so I'm going to take note of the inverted P waves. PR interval appears to be constant. Again, you would measure to be sure. PR interval is constant, but it's actually going to be short. It's really 2.5 boxes, so that's going to be less than 0.12 seconds. So I have a shortened PR interval, a narrow QRS complex, and a 1-to-1 P to QRS ratio. So because I know that inverted P waves in lead 2 with a shortened PR interval, narrow QRS complex. This is likely a junctional rhythm, and those P waves are being retrogradely conducted into the atria. I would be justified in calling this a junctional tachycardia. All right. A couple other different ways you may see a P wave in a junctional rhythm is you can see a retrograde P wave that presents as a slurred S wave in leads 2, 3, and AVF. So that's what we're looking at here, where this P wave is causing the S wave to just gradually come back to the J point, and that can make your QRS complex appear wide in a junctional rhythm. And then in lead V1, we have this here where it presents as an R prime wave or an additional rise above baseline. So that would be considered an R prime wave. And in this case, it could actually be a P wave that's occurring during that QRS complex. So we've discussed the intrinsic rates that can cause junctional rhythms. And now I want to talk about some of our reentry tachycardias. So the first one we're going to discuss is AV nodal reentry tachycardia. In this type of reentry mechanism, it affects about 10% of patients. And what they have is, in the approach to the AV node, they have 2 tracks, right? And those 2 tracks have different characteristics. So for a reentry tachycardia to occur, you really need 3 things. You need at least 2 pathways that are going to the same place. Those pathways have to have different properties or characteristics. And those characteristics, one of those areas should be slowing the impulse just enough for the circuit to complete its refractory period and fire again. And that's where a reentry circuit is born. It's most often caused by a premature atrial contraction in AV nodal reentry tachycardia. What happens 99.99% of the time in patients with this 2-track anatomy is the impulse travels down the fast track into the AV node. And then what happens is, remember we talked about it branches off, and it also starts to travel back up the slow track where it cancels out the impulse coming in from this way, and they cancel out right here, and the reentry pathway is not created. And that's what happens 99% of the time. Now, when AV nodal reentry tachycardia occurs and the reentry pathway is completed, right, you get an extra impulse that fires somewhere. So we have the normal impulse that happens, it cancels out, right, and then another impulse somewhere in here, it fires, and it sends its impulses down towards the AV node. When it comes to this track, it goes into those tracks and it finds that this fast track is still refractory. So that extra impulse gets blocked and is not able to go. But when it comes down to the slow track, because this slow track has a fast recovery time, it finds that it can travel through the slow track and goes into the AV node that way. And it splits off here. And by the time all that happens, the impulse finds that this fast track has had enough time to repolarize, and the reentry pathway is now born. And this is going to lead to a really fast heart rate that can cause decreased ventricular filling, decreased cardiac output, and is going to lead to compromise in our patients. So AV nodal reentry tachycardia is actually the most common SVT that we find in clinical practice. It's often paroxysmal, which means a rapid onset and rapid termination. The rate criteria for AV NRT is between 150, 250 beats per minute and regular. Your P waves can be buried in your QRS complex or occur just after. So when we talked about the pseudo S and the R prime in leads 2 and lead V1, you may see that here. You're generally going to be dealing with a narrow complex tachycardia in AV NRT. And if you're fortunate enough to see the premature atrial contraction occur, you're going to notice that that premature atrial contraction has a longer PR interval. And that's going to be because that PEC originated from somewhere outside the SA node. So it takes a longer time for it to get to the AV node. and it goes down the slow track. So as it goes down the slow track, it just takes it longer to get there, and you see a longer PR interval with that extra heartbeat. So let's look at our rhythm up here at top and do some interpretation. I can see that it's very fast. It's 150 beats per minute. You can look at it and tell that it's very regular. Okay. Do I see P waves? First glance, I'm going to say no P waves. I don't really see them. PR interval, absent. P to QRS ratio, absent. QRS complex, narrow. Yeah. And then I'm going to take another look, and I'm looking at lead 2, and on this EKG, you can see this slurred S wave in all of these leads. Almost makes it look like the QRS complex is wide, but really what we're seeing is we're seeing that retrograde conduction of the P wave. As it slows and comes through, it just occurs during this QRS complex. So this would be an example of AV nodal reentry tachycardia, which is a form of supraventricular tachycardia. The next reentry tachycardia we have is AV reentry tachycardia. So it's a little different than AV nodal reentry tachycardia. In this one, there is an accessory pathway, and think of that accessory pathway as a back door into the ventricles, where an impulse can just move right through it without any sort of physiological block occurring, like would occur in the AV node. In AV reentry, on a patient's normal EKG, when the heart rate's generally not extremely tachycardic, you can see what's called a delta wave, which is this right here. And this delta wave makes the QRS complex wide because it's basically hiding the PR interval and then the beginning of our S wave and into our R wave here. So you see how that delta wave is hiding it. And what's happening here is this impulse comes from the atria in green on your screen, comes from the atria, and it makes its way to the AV node. The AV node blocks some, slows it down, and then sends it throughout the ventricles. But while that's occurring at the exact same time, this accessory pathway, or this back door, sends an impulse through. So we get this very slow cell-to-cell contraction of the ventricles here. And that slow contraction of those ventricles is perceived on our EKG as this delta wave, where we get this gradual uptick into the QRS complex. And it's just hiding this normal conduction occurring right in here. Right? And that's where we see what's called our delta wave. And that would be called a Wolff-Parkinson-White pattern. It's also referred to as Wolff-Parkinson-White syndrome. And that's going to be important for us later on. An example of a delta wave, you can see here this in lead 2 down at the bottom. You can see the gradual uptick there. So the PR interval gets very short, and that's because this delta wave is making the QRS wide. I mean, it's in every lead here. So this would be an example of a patient that has Wolff-Parkinson-White. And us recognizing this on an EKG is going to make us aware that certain medications we would want to avoid in this type of patient. AV reentry tachycardia really has two ways that the tachycardia is created. You have orthodromic AV reentry, which is where the impulse is basically allowed to come through the AV node. The AV node exerts its physiological block, and then the impulse travels through the system. And when it gets back around the ventricles or wherever the accessory pathways is, it shoots up the accessory pathway, comes right back around, and finds that this area of tissue is ready to receive another impulse, and the reentry circuit is born. Now, it's important to note with orthodromic reentry tachycardia, the AV node, it still has some control, right? So it can still block some of those impulses and exert some of its control on the heart rate and the width of the QRS complex in this case. Now, in antidromic, what happens is the impulse basically comes through the accessory pathway first, and as it makes its way back around the AV node, remember we talked about the AV node not being good at retrograde conduction, so it can't exert any sort of block when it's going in the opposite direction. So that impulse travels to the AV node very quickly, comes back around, and then it just keeps propagating itself. In antidromic AV reentry tachycardia, you're going to have a wide QRS complex, and we'll get to that one in the next couple slides. Orthodromic AVRT, like we just talked about, is when the impulse travels down the AV node and then back through the accessory pathway that gives rise to a narrow complex tachycardia. It can be caused by premature atrial contraction, can also be caused by premature ventricular contraction. In this type of AVRT, medications that slow conduction through the AV node can be effective at treating the arrhythmia. You may not see a delta wave with orthodromic AVRT, and that's because there's no fusion of those impulses, because we don't have the direct cell-to-cell transmission as it goes through the accessory pathway, so we see a narrow complex tachycardia. In antidromic, like we talked about, the impulse travels down the accessory pathway first and then back through the AV node. So because the AV node cannot exert its physiological block, you get the direct cell-to-cell transmission, which equals the wide complex tachycardia. It can also be initiated by PAC or PVC. You see rates tend to be much higher in this type of AVRT. In this one, drugs that slow conduction through the AV node, they can actually be a little bit dangerous. So that would include adenosine, calcium channel blockers, and beta blockers, even vagal maneuvers. So with antidromic AVRT, because the QRS complex is wide, just a golden rule of pre-hospital management of tachycardic rhythms is you treat a wide complex tachycardia as ventricular tachycardia until proven otherwise. And in ventricular tachycardia, we're not going to be giving a patient diltiazem, probably not going to be giving them adenosine. In the pre-hospital environment, it's not completely necessary to be able to distinguish between ortho and antidromic AVRT without a previous EKG that shows the delta wave. It's really just an understanding that how the reentry tachycardia occurs and where the delta wave is coming from. And the presence of the delta wave in Wolff-Parkinson-White syndrome gives rise to wide complex tachycardias that can be difficult to identify and manage in the field, mainly because in a wide complex tachycardia, such as this, like a reentry tachycardia, medications that slow conduction through the AV node can be dangerous. So let's look at an example. In the rhythm up here, you can see that we have a rapid heart rate that's greater than 150 beats per minute. So the one here, this is very fast, 300, 150. So we're probably at least 170 beats per minute. It's a regular rhythm. Do you see P waves? Kind of. That's likely the inverted P wave right here. So in supraventricular tachycardias, you may not see the P wave, but oftentimes if you look a little bit closer, you find it somewhere else in the strip. So I have inverted P waves with different morphologies in this EKG. I have a 1-to-1 P to QRS ratio, or is it absent? Well, in this case, I'm going to say that it's absent because I can't really identify the P wave. I'm just looking at the change in morphology. So we have an absent P to QRS ratio. We have no PR interval, and I'm dealing with a narrow complex tachycardia. It would be considered antidromic AVRT if it was wide complex tachycardia. But again, we're managing that as VTAC until proven otherwise. And here's an example of an antidromic AVRT. It's impossible to tell the difference between this and ventricular tachycardia. In this type of patient, we would not want to use AV nodal blocking drugs for this patient. So diltiazem would likely be out of the protocol for this. If we're using adenosine, we would need to be very cautious with that. It's short acting, and it can actually, in some cases, allow us to identify the underlying rhythm. For Wolff-Parkinson-White wide complex tachycardia, procainamide is your first antiarrhythmic of choice, followed by amiodarone. State protocols for North Carolina, amiodarone is in the protocol for wide complex tachycardia. Our last slide is just discussing what supraventricular tachycardia means. So SVT is an umbrella term to describe a variety of tachycardias that can lead to hemodynamic instability. These tachycardias could be triggered by a reentry circuit like AV-NRT or AVRT, or from an area above the ventricles with increased automaticity that you may see with multifocal atrial tachycardia, ectopic atrial tachycardia. Causes of supraventricular tachycardia that might create a wide complex QRS could be SVT with a pre-existing bundle branch block or aberrancy, or antidromic AVRT. But again, always treat any wide complex tachycardia as VTAC until proven otherwise. In an emergent scenario, it's impossible and very difficult for us to distinguish between, is this ventricular tachycardia or is this SVT with aberrancy? In that case, we're going to follow our ACLS guidelines and protocols to stabilize the patient first, and then identify if there's any specific arrhythmia treatment that is warranted. Put down here in a little cloud, AFib and AFlutter, those are in a class of their own, and they're treated as such. We're going to discuss in the next module, Module 5, rhythm intervention, and this is going to be an important concept that we'll come back to. AV blocks. And the different types of blocks that we see, they're formed when conduction is prevented from reaching the ventricles. Now, it's important to note that with the different types of AV blocks, you can still have an underlying heart rhythm. For example, a patient with atrial flutter with a variable conduction. Well, that patient has some sort of AV block that the AV node is doing its normal physiological function of triaging which impulses it sends into the ventricles. So that's a form of an AV block. There's 3 types of AV blocks that we're going to talk about today, and these are most commonly going to be associated with bradycardic rhythms. We have a first degree AV block, second degree type 1 or type 2, and then we have a third degree, which is also referred to as a complete heart block. So let's start with a first degree heart block. So that's what we have here. We have a first degree AV block. About wrote a D there. We have a first degree AV block. And this is quite simply put, there's just a delay in conduction through the AV node of the supraventricular impulse. So the impulse is coming from most likely sinus origin. When it gets to the AV node, it takes just a little bit longer for the AV node to send that impulse down the line. That results in a PR interval that is greater than 0.20 seconds. And we can see that on the EKG above. Here, I'll pick a new one and look at. We can see that our P wave starts here and our QRS complex is here. Well, that is greater than 5 small boxes, so we know that our PR interval is greater than 0.20 seconds. In a first degree AV block, your P to QRS ratio should be a 1-to-1. Right? So you should have an underlying sinus rhythm with a first degree AV block. Your QRS complex should remain narrow unless there's some sort of pre-existing aberrant conduction like a bundle branch block. Our next heart block is a second degree type 1. Right? It's also referred to as a Winky-Bach AV block. In second degree type 1, what we see is this progressive lengthening of the PR interval until one of those P waves, it just fails to send its impulse. So by definition there, the shortest PR interval is the one immediately following the dropped beat. And the longest PR interval is the one just before the dropped beat. So we can look at our EKG here and we can find that. So if we measure the PR interval right after the drop beat, we're going to find that it's the shortest of our PR intervals, and we're going to find that this one right here is the longest PR interval, and there's our P wave with a dropped QRS complex. And you can see where the PR interval starts to progressively elongate until you have a drop beat. So there should always be one less QRS complex than P waves. So if we were to count this, I have 1, 2, 3, 4, 5, 6 P waves. So I should have 5 QRS complexes because I have that drop beat with a second degree type 1. In this type of block, it's most often a block inside the AV node where maybe the AV node is diseased and is sending impulses, and then it fails to send one. Our Movitz type 2, which is the same as our second degree AV block. So we have a second degree type 2 AV block here. In this block, the main difference is you have a constant PR interval and dropped P waves, right? So constant PR interval with a dropped P waves. You can have one or more non-conductive P waves in this rhythm, so you don't always have the finding of one less QRS complex than you have P waves. So you can have more than one dropped QRS complex. So if we look at this rhythm above here, we can measure our PR intervals, and we're going to find that these are constant PR intervals throughout this ECG, right? And then I have this dropped QRS complex that should occur somewhere around in there. So I have 2 drop beats here. I have another one here. So throughout this rhythm, I have constant PR intervals with dropped QRS complexes. That's enough for me to call this a second degree type 2. Now this type of AV block, it most often occurs in the bundle branches. So as the impulse leaves the AV node, it gets blocked before it can make its way out of the bundle of His and down both the right and left bundle branches to depolarize the ventricles, which is why you see in some cases a wide QRS complex with a second degree type 2, because there's a pre-existing block somewhere that's failing to conduct. I should note before moving on that in a second degree type 2, you can still have, and you often do still see, a narrow QRS complex. It's just most often you see a wide QRS complex with this type of block. In AV blocks, it's not always possible to differentiate between a type 1 or a type 2 AV block, and that's in the setting of a 2-to-1 conduction, which is what we're looking at here, where we have a 2-to-1 conduction where I have a P to QRS ratio of 2 to 1. So I don't have enough evidence from looking at this EKG to say that I see the progressive lengthening of a PR interval, and I don't have enough to say that the PR interval is constant and then a drop beat. So this is what we would refer to as an untypable AV block. Next, we have a complete or third degree heart block. This is characterized by complete and total blockage of conduction to the ventricles. So we end up with 2 pacemakers that have no association with each other. That also leads to a constantly changing and never repeatable PR interval throughout our EKG. So in other words, the P wave in no way is associated with causing the QRS complex. And that's one reason why we ask ourselves that question. A third degree heart block can occur at the level of the AV node or below, and that is where you can see variability in the QRS width. For example, you can see a junctional escape QRS complex, which is what we have here. So that's a junctional escape QRS complex, or you may see a ventricular escape QRS complex, which would where you would see a very wide morphology on your QRS complex, because the ventricles depolarization is going to move by direct cell-to-cell contact, which is much slower, and you get a longer QRS complex. So if we look at the EKG above here, and we can see that it's slow, it's bradycardic. Our art intervals look fairly regular. Do I see P waves? Yes, I see P waves. Are they similar in morphology? Yeah, those are pretty close in morphology. So I could estimate that they're likely coming from the same area within the atria. Now I'm at PR interval. Well, I can measure a couple PR intervals, but I don't really have any repeatable PR intervals here. I mean, you may be able to justify that it gets longer and then drops, but then you start to look a little bit closer at some of your morphologies, and you see that, yeah, I probably have a P wave in there. There's probably an extra P wave in my T wave here. There's probably one in here. So and that's a P wave right in there. So I have these P waves that just don't look like they're associated with my QRS complex, and that's how we're identifying a complete heart block, is by two separate pacemakers working independently of each other. AV block differentials. There's numerous causes for an AV block. These are some of the common ones you see on the screen. You could have fibrosis of your heart's electrical conduction system in the AV node and below, causing any of these heart blocks. Uh, Current or previous acute myocardial infarction and ischemic heart disease can lead to different types of AV blocks. Certain drugs that patients may take or even overdose on can lead to AV blocks, like, for example, a beta blocker overdose can cause AV blocks. Increased vagal tone, direct trauma to the heart, and other types of diseases all can lead to various AV blocks.